what we can get from the textbook. But if you, this is a paper that was published which looked at, about 300 or 400 excavated spine and all that from historical sites. And what they found is that you can see similar lesions in the skull even way back in as early as 3,400 BC. These things were there. So I mean, it's difficult to say conclusively that these are myeloma, but surely these are malignancies which have gone into the bone. This could be myeloma, this could be maybe another cancer, etc. But even back then these things were there, and probably lifestyle and increasing old age has probably increased the incidence of it. But nonetheless they were there even back then. So coming to the molecular basis of myeloma, the bone marrow cells are of two types. You've got cells that deposit bone, which are called osteoblasts. These are the cells that deposit bone all the time. Calcium, they deposit the soft tissue. And on the other side, you've got osteoclasts, basically, which are cells that eat up the bone. Okay, and the normal bone is sort of a balance of bone deposition and bone resorption, and it's a constant process. And there are some conditions where the bone resorption gets worse, and some conditions where the bone deposition is more. Osteoporosis, for example, is where you see that the bones have more on the side of being consumed by osteoclasts, whereas there are certain other conditions where the bones are very, very hard and dense, and this is where the blasts, the bone depositing cells are working hard. So myeloma cells have a very, very intense relationship with bone killing cells, bone destroying cells, and it's more like a sort of feeding each other sort of cycle. So myeloma cells make chemicals that provide soil for the osteoclasts to grow, and the osteoclasts will in return produce chemicals that will help myeloma cells to grow. So it's like a cycle that is good for each other, and at the same time they also make chemicals which are sort of inhibitory to osteoblasts, which are the cells that are supposed to lay bones. So it's a cycle which we believe is one of the key aspects why bone marrow likes to, or myeloma likes to go to the bone or even stay in the bone. Okay, and the main things that are responsible for this are chemicals like interleukin-3, interleukin-7, rank ligand, again interleukin-3. So many of the treatments these days are sort of targeting these key connections and trying to disrupt them. And you'll see that bortezomib Velcade is got anti-DKK1 activity, and we currently have a drug which is in clinical trial called denosumab, which is basically anti-rank ligand antibody. And so these are the drugs which are sort of we're trying to attack the relationship between each other and sort of trying to cut the roots, as it were, so that myeloma cells don't get a chance to thrive. So previously we had this, machine gun, or rather, atomic bomb approach. You put a big bomb and you kill everything. Okay, you kill the cancer cells, you kill the normal cells, you kill everything, and you get a lot of collateral damage. But what we're doing these days is getting cleverer and cleverer and trying to sort of identify those key things which are, unique to the situation, so that all this collateral damage is avoided. So in regular use right now are this class of drugs called bisphosphonates, and they are not just used for myeloma, they are also used for other conditions like osteoporosis, bone damage from other cancers, for example. So these are all drugs which all have a sort of similar effect on inhibiting this osteoclast. They're all similar, and the drugs that we use commonly are a drug called pamidronate, or Aridia. There's another drug called Zometa or Zolindronate, and these are the common ones that we use here. And they belong to the class called bisphosphonates. And as I told you before, they also have other role in treating osteoporosis or preventing osteoporosis, and also in treatment of patients with high calcium, because they can reduce the calcium level quite quickly too. So I don't know whether you can see this. So these are some of the clinical studies that have been done in myeloma using pamidronate and zolindronate. And I wanted to just have a look at this area. SRE stands for skeletal related events, okay, which means that fractures basically. And what we find is that if you look at the studies that have used pamidronate versus zolindronate or even pamidronate, you will see that there is an improvement in skeletal related events in favoring pamidronate So when you're using pamidronate versus zoledronate, it would seem that in patients having zoledronate, there is a benefit in terms of reducing fractures. So if you look at the history of bisphosphonates, pamidronate and zoledronate, pamidronate came up earlier than zoledronate, and it's thought to be less powerful, or zoledronic acid is more powerful. So as time has gone, we see that the stronger they are, the better in controlling or reducing skeletal events. So zoledronate is better than pamidronate. And clotronate was the oral drug, or the tablet that came around, and it's even before these two drugs came around. And you will see that they are there, but if you compare them, if you compare clotronate versus pamidronate, you'll see that the benefit is really, clotronate versus zoledronate. You'll see that there is benefit both in skeletal events and survival benefit in patients who take zoledronate. So what I mean to say is that the stronger the medicines are, the more likely to get a benefit in survival as well as in reducing skeletal-related events. But if you look at the early studies looking at placebo, you will see that even with clotronate, which is fairly inferior in this study, has some reduction in skeletal-related events. So they're comparing clotronate with no drug. So you found that when patients are not taking anything, even clotronate is better. Okay, but if you're taking clotronate versus zoledronate, you will find that zoledronate is better. So it's sort of increasing potency. You have more effect. But at the bottom line, if you're not taking anything, you must be at least on clotronate, which is the oral form, and thought to be less powerful of these three. The main side effects of these are renal impairment. So, especially zoledronate is not advisable for patients with very low kidney function. So, we will look at the creatinine clearance, which is a measure of kidney function, and reduce the dose accordingly. Pamidronate is fairly safe in patients with renal impairment. We just have to be careful of infusion, which is to be very slow in pamidronate. It has to be given at least over 2 hours minimum, if more, better, and 15 minutes for zoledronate. The other side effect is low calcium, and most of these are asymptomatic. And we do give calcium and vitamin D tablets to go with it. So most of the patients do not get symptomatic, they don't get symptoms of low calcium. The other bigger problem, much more dramatic, although not so common, is this problem called osteonecrosis. What happens is that it's basically chronic infection of the mandible, jawbone. And the reason why jaw is particularly susceptible is because that's an area where you're constantly having a lot of pressure. You chew all the time. Your oral cavity is teeming with all sorts of infection, and it's a right soil for getting problems. So if you have a small infection, you're likely to make it much more flared because of the existing, we call it the bad environment inside the mouth. And osteonecrosis is very common, and it's almost exclusively, described in the oral cavity. And you can see that the incidence of it goes up as you get stronger and stronger. So with alendronate, the incidence is 1%. With zoledronate or Zometa is 4%, but even then it's 4%, and it's not as high. And if you look at it, most of them do resolve, but recurrence may happen. So the main thing to do is to have a very good dental checkup before starting, and make sure that there's no active infection when you start the treatment, and also get regular annual follow-up by dentists to make sure there's no infection. If you're going to have some procedure like extraction or some treatment, it should be done before starting treatment. And if you're on treatment, you must be at least stopping it for 90 days before you resume the treatment, so that the infection is completely healed and there is enough time for it to go back to normal before you start with bisphosphonates. So if anybody is on treatment, you must always tell the dentist that you're on this medicine, okay? And likewise, when we get a new patient, we always check and send them to dental doctors to make sure there's no active infection before starting treatment. So the recommendation from International Myeloma Working Group, which is the international organization that looks after or gives out guidance to myeloma about myeloma treatment, is that all patients should get treatment up to 2 years at time of diagnosis. Now, after 2 years, if you're in very good control, or CR, complete response as we call it, then treatment is no longer needed. But if there's any evidence of disease beyond 2 years of therapy, continued treatment is recommended. So, because, as I told you, myeloma and bone are sort of feeding each other, treating bone disease is just not treating bone, it's also treating myeloma in a way, because we are feeding, stopping the feeders that will help the myelin cells to grow. Okay, so many times when patients are not in remission, we don't think about it. But when they start having some treatment, they have to go back to getting treatment. Zometa, when they get proper treatment for relapse. Right now, let me go back. So just a reminder, there are 3 phases generally of myeloma, starting from this earliest phase called MGUS. MGUS means that MGUS stands for monoclonal gammopathy of unknown significance, okay? And we don't need to know that. But what it means is that we don't know the significance, in the sense that quite a high number of patients in the general population tend to have MGUS, but only a small percentage of them ever become myeloma. So for most of the patients, they don't know they have MGUS for the rest of their life. They would live and die as they never never had myeloma or MGUS. And we don't have routine blood tests to pick up unless you specifically think of it and look for it. Some of the patients that come to us are patients who had, say, healthy blood donors who go and have blood tests. They have to be mandatorily having blood tests. These are the ones who have regular blood tests for some reason and these get picked up. But patients who don't feel unwell, we don't do blood tests and many blood tests are missed. And in these patients who don't get or require treatment, they don't need treatment for bone disease because the myelomas, whatever it is not requiring treatment, so we don't have to treat right now. There is this group in between called asymptomatic myeloma where we know that it's no longer MGUS, but it's not really myeloma, it's in between. In such patients currently, we don't have any real guidance for treatment. When it comes to bone treatment, it's something that you need to discuss with the doctor. It's not as clear as in MGUS where treatment is not recommended, but in asymptomatic myeloma, maybe there's a role in starting bone protection treatment, and that's something that you can discuss with the doctor. Same in another condition called solitary plasmacytoma, where there is no evidence of myeloma elsewhere, but it's only in one place, and it is a localized place. That's also not an uncommon thing to see, and it's not really treated as myeloma because we don't have to go with anti-myeloma chemotherapy. Many times a local radiation will do for treating it. So these are the 3 types of, 3 variants of myeloma, just to give you an idea. So, in the solitary plasmacytoma where there's myeloma in one place, not myeloma, the tumor is in one place, we again, treatment is not required unless, there is coexisting other problems like osteoporosis where you treat anyway. So it all depends on the situation, but in myeloma, treatment is required, and that is without a doubt. Now, coming to the other things you can do for bone, I'm going to talk about this procedure called kyphoplasty. So kyphoplasty is sometimes used when the bone is very badly damaged in the spine, and what is many times patients have very bad backache, and this is because the spine is collapsed and is crushing and pinching the nerves and can cause very bad pain. And it doesn't really get better with treatment of myeloma because once the bone is damaged, it is damaged. So there are things that we can do to help the spine and improve the spine. So maybe you can just show the video of that.
The real-time X-ray of the spine, viewed on a video monitor, a trained spine specialist creates narrow pathways in the back on both sides of the fractured vertebra, using a hollow tube-like instrument about the size of a pencil. A small balloon is inserted through each tube and then carefully inflated in the fractured vertebra in an attempt to restore the vertebra back to its normal shape. Physicians often call this reducing the fracture. The balloons are then deflated and removed, and the cavities left by the balloons are filled with bone cement to create an internal cast and to stabilize the fracture.
So I just put this in because this is another problem that many times will take away the quality of life in patients with myeloma, very bad backache. So we work very closely with bone doctors, spine doctors especially, to see whether there is any area that can be treated using this thing, and increase the height, and it will help to relieve the pressure on the nerves and reduce the pain. So coming to the next, so we have a few other, as I mentioned in the previous slide, a few other agents which are currently in clinical study, and some of them are approved already in treatment for bone disease in other cancers. So for example, there's this medicine called denosumab, and it's approved already for treatment in cancer because of breast or whatever going into bones. Whereas in myeloma, the clear evidence is not clear. So currently, we have phase 3 study which is comparing this medicine versus Zometa to see which one is better. So there are new drugs in the pipeline which are being explored in this area, and there are other drugs like the DKK1. I told you about the other slide where there's this molecule called DKK1, which again has somewhat similar effects like rank-like and rank-down. So these are all new drugs which are currently in clinical studies, and in the next few years we may have new drugs coming into the market showing benefit in patients. So briefly on impact of new medicines. So going back to the very first slide, we knew that myeloma and bones are related to each other, and one can help each other. If you kill one, the other one goes down. So the newer agents have been tremendously successful in clearing myeloma and improving survival beyond anything else could have done in the 80s. So clearly, these drugs, without these drugs, myeloma would have been an orphan child. In the 80s, nobody wanted to be a myeloma doctor. Everybody, would like to run away from myeloma because the treatment was very bad. Okay, but in the 1990s and 2000s, we've had an explosion of new drugs, and now everybody wants to be a myeloma doctor. Okay, so these are just the start of the line of novel agents which are out there, and you will see that Velcade and lenalidomide have made tremendous strides in improving myeloma, and this has also reduced the problems with the bone somewhat, because they are very fast in affecting myeloma, killing myeloma, and thereby sort of killing that cycle of myeloma bone helping each other. But that doesn't really take away the requirement for getting bisphosphonates still. Okay, they are good, but they are not the only thing that would do it. So we still have to continue with the treatment that you would do for the bone otherwise. But the impact is even better if you take both. So other supportive medications that you take are generally, we all give everybody calcium and vitamin D3, and especially people with dark skin, they tend to have lesser vitamin D because of the skin blocking the rays. So some of the patients might get a vitamin D level check, and they may need higher than normal doses. But everybody should get calcium and vitamin D to supplement. The calcium is a key component of bone. So when you're trying to develop bone, you need calcium for the bone to grow, the bone to deposit. Now, role of radiation, not in the same line, but radiation also has a role in helping bone. It's not like the bisphosphonates or the Velcade I'm talking about. When you're in very bad pain because of fracture of the bone or myeloma pressing on something very close to it, sometimes what we can do is to give a shot of radiation in that area, and it sort of kills myeloma. And the benefit is that many times when patients are too sick to get very strong medicines by mouth or by drip, it's easy to give them radiation, and it doesn't act very fast because radiation takes its time. But it takes about 10 to 14 days from the start of radiation for things to visibly improve. But it's something that we can use, and it's useful in patients especially who are looking for symptom control because we think that they are too sick to too weak to get strong medicines. So it has its role in helping bone pain, but it's not really curative, or not curative, but as treatment oriented as bisphosphonates or myeloma treatment. So just to summarize, bone damage is a major problem in myeloma, and treatment of myeloma and treatment of bone disease must go hand in hand. Bisphosphonates are the mainstay of treatment, and ideally we like to give them for 2 years if there are no side effects and the patient can tolerate it. When the myeloma relapses, we should restart the treatment with the bisphosphonates, and vitamin D and calcium are necessary to take, and there are new medicines in clinical trial. Now, beside all this, it's very important to have a very active life, so that the bones are, when you exercise, we know that the rate of bone thinning goes down. So, having an active life is very important. Walking every day, doing a bit of exercise, all these things help to deposit the bones as well. We know that when people rest on the bed for a long time, it's an easy way of losing muscle, losing bones very fast. So, patients who are bedridden, they lose muscles a lot faster than when they are mobile. The same thing applies to patients who go to outer space. They thin their bones very fast as well. So it's very important to have an active life to keep your muscles, and your body working so that the bone osteoporosis rate is very decreased. And that's the end of my talk.